Well, hello, everyone, and thank you for attending our COVID-19 webinar follow-up series. My name is Holly Foxworth. I'm one of the registered nurses here at Axiom Medical, and I'm also joined by Axiom's Chief Medical Officer, Dr. Scott Cherry, and Chief Marketing Officer, Dara Wheeler. So thank you both for joining today.
Thanks for having us.
Yeah. So for those that may be a little bit new to Axiom, let me have you go ahead and just kind of introduce yourselves and tell us a little bit about what your background is and your current role. Dr. Cherry, do you want to maybe go first?
Sure. Yeah. Good afternoon, everyone. I'm a board-certified preventive medicine and occupational medicine physician. I've been supporting military, government, and industrial operations for the past 15 years. And here at Axiom, I'm the Chief Medical Officer. And for the past, I guess since March, we've really ramped up our preventive medicine strategies supporting population health in the workplace.
Great. And Dara?
Thanks, Holly. I'm really excited to be here. So my name is Dara Wheeler, and I'm Axiom's Chief Marketing Officer, the other CMO here. And I've been with Axiom for 15 years, and we are a really great company that is here to help employers and employees try to stay healthy and safe in the workplace. So I'm happy to be here and talk about this important subject.
Fantastic. Well, we were thrilled to have so many that were in the webinar this last week whenever we spoke about some of the COVID-19 vaccines and therapeutics, and you both had shared such great information, not just where we are currently, where we stand, but also kind of what it is that we need to be looking forward towards. What does that next process look like, that next step, the vaccines, and what do we do to maintain some of the layered approaches that we've already started with the PPE and the testing and the health statuses, et cetera. But Dr. Cherry, I did want to mention to you or kind of ask, you briefly spoke about sort of the vaccine safety, and then we've seen this week, it's really been kind of a milestone week in terms of approvals, and now we've seen that some of the first vaccines have been administered, but it seems to have gotten a lot of attention at several allergic reactions that had been reported on. So could you maybe walk us through that and provide some insight as to whether this may have been an isolated occurrence or whether we should expect it on a larger scale?
Sure, and maybe before I do that, I'll talk about side effects and contrast it with allergic reactions. So it's very well expected that people will have side effects, and really, side effects with medications are usually unintended effects, where the side effects that I think with vaccines are kind of an intended outcome, where people actually feel sick, where they might have a fever, chills, just kind of light symptoms of being sick, because that's really the symptoms of your immune response to the vaccine. So in general, I actually wouldn't call those side effects in the traditional sense, but those can be heavily contrasted to an allergic reaction where people have a very intense reaction where they might have trouble breathing, their airway may be shutting down, swelling in the airway, the lips, the face, and that really is a true medical emergency that requires a very quick response with adrenaline or an epinephrine pen. And so I think that's what has been in the news lately, Holly, those few cases from the UK where vaccine recipients had really a true allergic reaction that was life-threatening, requiring epinephrine to resuscitate them, to bring down the swelling. And so, we always think about safety, but that's relative. And when you're applying a vaccine to a large population, even with very high safety ratings, there is that small potential of allergic reactions. So I think with especially new vaccines, wherever the person is going to be getting the vaccine, it's really imperative that those facilities have those epinephrine pens or EpiPens. That it's very common for people with peanut allergies or bee sting allergies to have them on them, to actually carry them with themselves. But it's not unexpected. It's not. I guess from a reasonable perspective, it isn't uncommon to have a few of these over a large population. So, but I think the news also is wanting to be very quick to report on anything that's happening. So, I think before we've discussed that you really need to be disciplined on how you intake your information, and so, obviously the news is really on the front lines of reporting breakthroughs in medical science, maybe even before the medicine is reporting through the formal journal, through the peer review process. So again, I think an easy way to think of it is if there's a story to it, or if it evokes emotion, you're receiving more of an entertainment than maybe science, although science may be in some of the news reportings.
Mm-hmm. And has there been some discussion in terms of maybe giving some guidance that if maybe somebody had significant allergies or was specific to medications that they had reactions to in the past, do you anticipate that we may see some advisories there on maybe they should not take this vaccine?
Correct. I don't think it's clear what is the component of the vaccine that's causing the allergic reaction. People may react to the actual infectious agent, or they may react to what we call an adjuvant, which actually makes the vaccine more immunogenic or causes a bigger reaction within the human body. And so I think right now they're using the most conservative approach of, if you have any medication allergies, or especially have had any previous vaccine allergies, then you should hold off. And so I think there's a lot more to be determined, but this is making news very quickly.
Yeah, for sure. And I think it also brings kind of the point of, and hopefully this will answer some questions as to why it is that, if you do get the vaccine, they're going to tell you to at least stay in that one location so you can be monitored at least for 15 to 30 minutes after that, just to make for sure that nothing occurs there. Perfect. Anything you wanted to add to that, Dara?
No, I think Dr. Cherry explained it really well. I continue to echo what he's saying about making sure you're getting your news from credible sources and reaching out to people that are experts, or really trying to find out what the science is behind the information.
Yeah, definitely. Well, and I think this additional information will help others to be able to make some of those informed decisions about their health that we spoke about last week. So great job. I appreciate the additional explanation there. All right. Well, we had a lot of questions actually in the webinar this last week, so we'll get started on those. The first came from Florence, who was wanting to know, let's see, how fast or how rapid the virus is actually mutating.
Mm-hmm. There's, again, common theme here. It's very early in the knowledge of the virus, but months ago, there was some studies showing that COVID-19 was actually mutating very quickly, and that potentially there was already new strains across the pandemic in different geographies. And then a recent study actually indicates the opposite, that in general, if you look at how the virus expresses the proteins on its surface by which it gains access to a host cell, there's not a lot of genetic variability yet. And there was really good discussion in that article that stated that, the flu actually has a tremendous genetic variability within the species every year, and that it has and it's able to change also from year to year. And the authors were actually stating that that's probably a function of how long the infection has been amongst us. So flu has been around for hundreds of years, and SARS-CoV-2, which is the virus for COVID-19, really is only starting to play out its life cycle in us this year. So, hundreds of years versus less than a year. But I think in general, when you look at coronaviruses, they do have the ability to have genetic variability, which allows for the common cold to remain as an infectious agent in humans for the past 100 or plus years. So there may be just a lot of nuance in these studies, but I think from a practical perspective, I would say there is variability.
Okay, good deal. All right, let's see. Sienna had the next question. I thought it was really good. And if I'm not mistaken, I think that this may have actually been on the CDC agenda to discuss this week, but you may have some additional information, Dr. Cherry. Wanting to know if they would still need to get the vaccine if they've already had COVID-19.
I think the indications may not be formalized yet for the vaccines, but in general, I don't believe like natural infection confers long-term immunity. So the vaccine is probably going to be needed irregardless of if you've been previously infected. But I think that's to be determined through evidence. But I think that's where they're heading towards in these vaccine studies.
Okay, good deal. And then it looks like David had a question about the newest CDC isolation guidance for exposures. He was wanting to know if his employees would still need to quarantine for 7 days if they were exposed, but take a rapid test, which had a negative result.
Yes, that's my understanding, that the new guidance allows for a reduced social isolation period for those that are exposed but remain asymptomatic.
Okay, so, but just to clarify then, so if they would still need to, so if they were exposed, they would still need to quarantine even though they had a negative test?
Correct. So the previous guidance was to isolate for 14 days, which is the full incubation period of COVID-19. And so the new guidance allows 10 days without a test. So they've shortened it 4 days. And then if you get a test, then you could actually return or discontinue isolation by day 7.
Okay.
There is like a residual risk that the CDC advises that I concur with regard to probably about a 1% on average residual risk of infection with the 10-day isolation period. And then if you do the 7-day isolation period with a negative test, you probably have a 5% residual risk. Mm-hmm. So I think it's a business decision for every business to determine kind of the balance of their human capital planning and their ability to get their work done based on their infection rate and absence from those.
Yeah, I was going to add to that a little bit, Holly. One of the things that we've been advising clients on is that although it does say with a negative test, and Scott, you can correct me if I'm wrong, I don't think the CDC has specified on which day to get that negative test. And so we want to be very careful about what day that test is completed on, because if you're too early in the infection cycle, that test is going to be negative, and then you're going to return somebody to work that is potentially positive. And so you want to be very, very careful about what protocol you establish for a testing protocol. So if you test, we definitely advise it be after day 5 at a minimum.
Good point.
Yeah, I agree. It's interesting, CDC changing this guidance. It informs me as a consumer of the guidance that the risk tolerance that they're at least willing to provide official policy guidance on. And it just depends on, again, that business and the business's outlook on risk and then also their ability to function as well. But, I agree, Dara, the later you can wait in the testing in that incubation period, the more valuable the test is. And just to look at the epidemiology of the incubation period, the range is 1 to 14 days, but the average is actually 5 days. So by day 5, at least half of the people that are exposed who are going to get infected will get infected. And so by day 11, you're at 97%. So that's where the CDC, I think, has looked at some statistical analysis to obviously day 10. You're only probably at 2.5% left that's going to convert, if they're going to convert to infection. And then the testing component to me has been just very interesting. But, with so many asymptomatic infected people with COVID-19, I think that's why they kind of, I would just say they sprinkled that in as another mechanism. So you have different tools of dispositioning your workforce or the population.
Yeah, and I know Dr. Terry and I could probably talk about this for a really long time, and I do think that testing is sprinkled in. And I'm glad you made the point. Symptoms trump everything, of course. Mm-hmm. But if we have a large asymptomatic positive population, that testing component becomes critical, as well as the isolation period.
All right. Great information. Okay, let's see. The next one came from Judy, and Judy was asking, what is Luciferies and why is it in the vaccine?
I actually saw that question in our chat box last week, and so I was able to actually kind of look into that. It actually is not in my working knowledge, so I did look that up, and I wasn't really able to see the connection with the vaccine. Obviously, I'm an occupational medicine specialist, and so I have a functional knowledge of the vaccine and its pros and cons and things like that, but I'm not aware of that, so it's hard for me to address kind of that specific question. And it may come to light in the future if there's more time for that to be evident, but I'm actually not aware of that, so I can't address it.
Okay, perfect. All right, and the next one was from Patricia, who had a hot topic question. It seems like we've been covering this one a lot, but she was wanting to know if they will be able to require employees to take the vaccine before coming into the workplace whenever it is available.
I have a lot of experience with vaccinations in the workplace, and especially with healthcare workers for large health systems where really, there's an expectation that healthcare workers get kind of the annual flu vaccine, and they get like the hepatitis B vaccine for bloodborne pathogens prevention. And hospitals really have a difficult time requiring it as mandatory. I think it's pseudo-mandatory, but there's ways to for employees to say they decide not to do it for many different reasons. And I think when you extend it to the general population or to a general workforce, it's probably going to be even harder. Mandatory vaccinations is a very strong-armed approach that I just don't think it's going to happen in a free country. But I could be wrong, but I just don't really see that happening.
Okay. I agree, and we've talked a lot about this at our executive level, just in general. I think it'll for some industries, it'll be heavily encouraged. Right. And like Dr. Cherry said, it may be pseudo-mandatory. However, for the general public and normal organizations that maybe aren't frontline healthcare or in very specific industries, it'll be a lot harder to enforce. But what I do think employers will do, they may not require it, but they will definitely be interested in tracking vaccine status.
Absolutely. Yeah, definitely. All right. And then Gail, the next question came from Gail. It looks like Gail's question could kind of go in several different directions, but she was asking what entity or who will oversee the vaccines are appropriately administered to frontline workers and nursing home residents. So I don't know if maybe you want to cover that from both sides there. Maybe the first piece being who would be responsible for following the order of prioritization, and then maybe the second piece of that, maybe take it from the side of the license or skill level that would be required to administer those.
So if this is in regard to the strategic rollout of vaccines to special populations first, so the highest risk, which we talked about last week, would be healthcare workers and residents of nursing homes. I believe organizations will be receiving those on a prioritized basis. My training in public health emergency response before COVID in the military actually would go as far as to say the U.S. Marshals would actually escort the supply chain, so the trucks or whatever mechanism they're going to be delivering it. Which back then, before there was really a significant pandemic, it seemed strong and very Hollywood-like to me. But I think anything could be happening, right? If depending on how things go. I think if the mortality rate of COVID was much higher, that would actually be a really significant risk. But I think what will be happening is that populations will be identified in that phase 1, and so those vaccinations will be issued based on that priority level, and then that's it. So there's really a fiduciary responsibility of the leadership of each organization, so the hospitals and the nursing homes, to really be, I think they'll be held at a fiduciary level that these are meant for those populations and cannot be given out to any other group at that time. And was there a second part to that question, Holly?
Yeah, we talked about maybe kind of like the license or skill level. So, I mean, I think there's been some discussion that maybe we'd have a pharmacist that could administer, obviously nurses could do that. Maybe we'd have medics. I think there's probably a broad range there in terms of who may be able to administer these vaccine medications. Yeah,
so definitely the skill types that you mentioned are appropriate. Sometimes medics and medical technicians can be issuing vaccinations under close supervision if they've been trained appropriately. I'm trying to think what other roles potentially. I think that will be really the majority of them,
Yeah. I mean, I guess especially maybe in a longer term facility, some of the nursing homes, maybe we would see, I guess there's a possibility that we may see med aides that, that's their sole job is to administer medications. But yeah, I definitely think that those with the licenses, that would be the ones that we would focus on. Okay, let's see. We've got several more. Audrey had asked whether there's been any discussion as to the cost of the vaccine and whether employees or the employer would be responsible for the cost.
I haven't seen any discussions in reality, like documented. I haven't seen any documentation about cost. I know we've seen politicians say that it would be free or potentially no cost. So no cost is actually an interesting verbiage where potentially there's no out-of-pocket cost, but there's still a charge to your insurance. I would expect insurance to cover it. If employers are going to require it or even facilitate it, then usually that means they'll pay for it, kind of like the flu drives we see every year for our clients.
Yeah.
So, but yeah, cost has not been on I haven't seen that on the radar. Holly or Dara, have you seen anything with regard to cost?
Yeah, I watched the other day and a special, and they were speaking about that there wouldn't necessarily be a cost that was going to be associated with that in this first round. However, we may see that clinics are going to charge the insurance company for the actual administration of the vaccine. So that's the only cost that I've seen that has been discussed. Dara, you may have something more.
Yeah, no, I agree. I've heard the same as kind of both of you. I think that there's going to be probably, my guess is, quite a few government subsidies to this, as there already have been. I think the government has guaranteed purchase of most of the administration of the vaccine, or the actual vaccine supplies themselves, which is what has definitely led to the speed to market, and kind of unlike the rest of the typical vaccine creation that we've seen over time. So it'll be interesting to see. I think those first few rounds of vaccines, we may not even get access to what the cost potentially could be. But I do think, I expect it to be either at what the flu vaccine is or lower.
Yeah, agreed. Okay, let's see. Brian had asked what the current goals were for getting back to our pre-COVID norm, as he feels like that there's been some changes along the way. So that one seems kind of broad. I don't know, Dr. Cherry, do you have any thoughts there? or
Let's
Dara?
see. My dog was actually barking during this one. So what is the goal of getting back to pre-COVID normal? It seems like the goal continues to change. Yeah, I agree to the perspective, Brian, and I think it evolves. Our experience actually having done, tens of thousands of cases now, from the beginning, we were thinking, okay, let's create in the absence of a test, let's create a syndromic surveillance tool. And we thought a technological, a tool like a test would actually be the solution. And then obviously face mask and environmental, kind of all the layered approach, self-attestations to personal health would help. And then I think eventually vaccines, before they became a reality, were really the silver bullet, so to speak, to be the ticket to back to normal or pre-COVID. As I've looked more intensely at the vaccines, what's available at least, I don't actually think the vaccines are going to allow us to return to normal, at least with the current data that's being provided. Right now, the vaccines, their outcome of interest is actually prevention of severe disease, not necessarily prevention of infection. So I believe, still about 5% of infections require hospitalization. So the outcome of the vaccines are to really prevent severe disease needing hospitalizations or ending up in death. There may be a second outcome from the studies to prevent infection. Infection is actually what's driving, in my opinion, the socio-political pressures of shutdowns and all of the different ramifications we're seeing, potentially like from Cal OSHA for more burden to the employer for testing, surveillance if they have 3 or more cases. So I don't believe the current vaccine, unless there's another outcome that can be documented that prevents infection. So the way the vaccines right now are showing efficacy, it's preventing severe disease. So that actually will not effectively provide herd immunity, even if a large proportion of the population is to be vaccinated. So, but again, those secondary outcomes may be published eventually too. But right now, we just don't have any data to show any reason why the vaccine would prevent infection and herd immunity.
Okay.
I think that's such a critical nuance. I really, as we talk about getting back to some sort of normalcy, I think we've been holding out hope. We're human. We want hope that this vaccine would bring us back to some semblance of that normalcy. And I think, just to Dr. Cherry's point, it'll reduce your risk of potentially the mortality rate, or the potentially death or severe symptoms, but it may not, at this point, stop any spread of an infection. And I think that we're hearing a lot of terms thrown around in the client conversations we have and our colleagues. There's this concept of the new normal, and I think it's a bit of a trite term, but I do think that what we see is post 9/11, a lot of these changes in security and safety that we've never gone back from. And I do think that what we're seeing is some similar behaviors. I think that forever travel and meetings and things will shift. I find it very hard to think about going back to an in-person meeting and shaking everybody's hands, for example, without standing there with a huge bottle of hand sanitizer and making sure everybody's sprayed down. I do think behaviors will continue to stay pretty locked in to paying attention to infectious disease, at least for a cycle or two. So it'll be interesting to see how this, quote unquote, new normal is for us.
Absolutely. Yeah. All right, let's see. Laura had asked if the vaccine could be inactive if it's not stored at the appropriate temperature.
Yes, we discussed kind of those extreme low temperatures that are required right now for the 2 messenger RNA vaccine candidates that we're seeing. And so, yeah, really that's, if you can't maintain that cold chain of logistics from the production of the vaccine to the in-state delivery of the vaccine to someone, the effectiveness will definitely degrade. So
that's gonna be a huge challenge for sure.
Mhm.
Yeah. Okay, let's see. And then Shirley asked if a mask will be required once you have had the vaccine. And if so, what kind of a time period would be expected that you would continue to have to wear a mask even after you had received that?
So this actually ties in nicely to what we were discussing before about the outcome right now being tracked for the vaccines is preventing severe disease. So it doesn't prevent infection. There's already a large proportion of asymptomatic infected people. And so my thought would be that you would still need to do all the preventive measures that you would have to do without the vaccine, because the vaccine, at least to this point, which again is very early, so it's not saying anything negative about the vaccine. It's just that there's no data that would help me advise clients or provide population health consultation that masks wouldn't be required in a fully vaccinated population, because again, the vaccine doesn't prevent, it's not, right now there's not evidence of preventing infection. And so maybe I'll just spend another second on that, because I know it may sound very bizarre if you're not providing full attention, but there's people that are infected. You can actually be infected with a disease but not be symptomatic. Actually, an interesting maybe example is HIV, where people can be infected with the virus but not manifest any symptoms. So they're infected with, HIV, but do not demonstrate, the acquired immunodeficiency syndrome. It's only once the immune system is degraded enough to where you start manifesting those symptoms. So again, a vaccine can prevent severe disease or infection. And that's what we actually see with the influenza virus. My old residency director, I thought he said it quite tersely or jokingly, but it's resonated for the last 15 years, where, the flu vaccine doesn't prevent infection. It doesn't prevent you from getting infection. It prevents you from dying from the infection. So it's nuanced, but it makes a big difference, because this question perfectly highlights that, because there's a major manifestation of that. And so a contrast would be the measles vaccine, which provides complete immunity and lifelong immunity. So even if you're exposed to measles, you really have no risk of getting it,
Yeah, definitely. We did have a comment that had actually came in while we were on the chat here from Mohammed, that's in New York. He actually works with us, and he was asking. He asked some great questions here. He had mentioned that he is a public health professional, and he understands the importance of vaccination. But he wanted to know, what are some of the ways besides education that we can change people's perception of the vaccine? Great question.
Yeah, this is a great question. And, I think vaccinations before COVID were starting to, there wasn't really a consistent view of vaccinations. I think vaccinations started getting a bad rap from, certain vocal people about, I think it's called anti-vaccination and things like that. And so it's not new to be skeptical of vaccines, but a well-established vaccine like measles is amazingly, it's almost akin to a miracle, where measles could easily wipe out 25 to 50% of the children in a village that had never been exposed to it before. If you were to vaccinate that whole village, there would essentially be no morbidity or mortality from an exposure. So that's really almost a miracle, I would say. Influenza vaccination is less effective in infection control, but it still does provide a lot of protective measures for severe disease. COVID, I think, the COVID vaccines especially challenging. One, because it's a vaccine, and two, because it's a new vaccine for a new disease. And on top of it, it's a new technology, this messenger RNA, which I think we spoke about a fair amount previously. So, this would take really, I think this is the work of public health. And so I appreciate Muhammad's question. I don't have a kind of a succinct solution, but it would really need to be a kind of a multimodal approach of education, reviewing of the data as it becomes more available, especially about safety, because again, the news just kind of shining the light on two anaphylactic reactions. I think the common person doesn't realize anaphylactic reactions or severe allergic reactions are common for other vaccines as well. So I think maybe I'll lean back on Dara and Holly too, if you have any thoughts, but it would really take some deliberate thinking on this to really to find solutions for this.
Yeah, Dr. Scott and I talk a lot about how do you change behavior, and it's really, it's kind of the crux of the issue in occupational health and medicine, and I think just medicine in general in the US and across the world. And when we learn more about prevention versus reaction in medicine, I think that's another critical turning point in the way we think about this. Now, we know that changing behavior is really difficult. And so I think Muhammad's point about education is critical, but, education is one component. How do you really, we've talked a lot about the information out there is so quickly moving and missing information or lacking information or not necessarily fully vetted scientific data. So it is not an easy question. I don't think there's a really easy answer to that question. But I do think as a public health professional, your biggest tool is going to be education, getting access to experts, working with organizations like Axiom who are weeding through a lot of the noise to try to bring really thoughtful responses to these questions. It doesn't have to be Axiom, but I do think that you need to find somebody as a thought partner, especially as an employer, to think about these things and to create really good policy process and a way forward for your employees in 2021.
Absolutely. I completely agree. Well, I know that we kind of went a little bit later than what we normally do here, but this is great information. We had a lot of great questions, and I really appreciate you guys joining and providing the additional explanations here. Any closing thoughts before we go?
I think what I've seen primarily in media are kind of external things that would help with COVID-19. I think there's a lot of internal things each individual can consider to do to make them more resilient to COVID and to life challenges in general. And so I really would encourage those who don't have a primary care doctor to get one and to determine if they're one in the vulnerable populations, because that's a different, I see really there's two big populations for the vaccine or for COVID in general. There's kind of people not in vulnerable populations or categories, and then those that are in the vulnerable categories. So it's important to know if you do fit into those. And so if you haven't had a physical in a while, it's important to get a physical, because if you have, high blood pressure, which you may not be symptomatic from, or even early diabetes, those are very important things to pick up as soon as possible. But again, if you're in those vulnerable categories, you can do things to really improve your wellness by maximizing those disease states by, exercise, nutrition, vitamins, but really partner with your primary care doctor about really a strategy tailored for your individual case.
I think that's such a great tip, Dr. Cherry. I think that is something that has been missed in a lot of this too. And if you don't feel even comfortable going into a doctor's office, you can do that. There's a lot of telehealth options out there that are great. And I think the other piece that's been interesting is, I know we've talked a lot about the psychological and mental and behavioral health components of being in isolation. And a lot of anecdotal stories that I've heard from coworkers and family and friends are that one of the things they feel like they can control is their health and their wellness. And so they've taken opportunities, kind of, there's extremes both ways. We've seen lots of people become very obsessed with exercise and diet and fitness, but then you've got the other extreme as well. But I do think it's a great mindset to think about, you know, what you can control being at home. And one of those key areas is the food you eat and the exercise you get in a given day. So I know I've taken that to heart recently, and I know a lot of other people have too. So it is something that, as we think again of coming out of this COVID era, maybe even just a little bit, we will need to go back to addressing the underlying health issues in America, like heart disease and diabetes.
For sure, for sure. Well, thank you both again. I really appreciate it. Just a few quick mentions before we do go. We've made a minor tweak to our webinar schedule. We've had a lot of questions that have came in about the new Cal OSHA standards, how that's going to affect them, how it's going to affect you, what are the different components of that. So we have actually moved that up on the schedule. We're going to have that next Thursday. That's going to be December the 17th at 1:00 p.m. Central. And that will include not only Dr. Cherry, but we're also going to bring in our Chief Legal Officer and HR Officer, Chuck Cable, so they can both take your questions. So if you have questions that you want to submit in advance, we'd love to have those. You can submit them via email to us at coronavirus@axiomllc.com. Lastly, we do have a new white paper that covers everything about how it is that you can appropriately manage the flu during this pandemic. And so you're welcome to download a copy of that from our website. It's free. And then if you have any questions about checking to work, checking to school, COVID testing, whatever it may be, we're always happy to walk you through those. So thank you again for joining, and we will see you next Thursday, December 17th at 1:00 p.m.